Okay, we have one more talk before lunch, the dubious honor of being the last talk before lunch, Dr. Ljubenkov. But I am delighted to introduce our next speaker, who is Dr. Peter Ljubenkov from UCSF. Peter is a very active researcher at UCSF. He's a behavioral neurologist. He's running multiple clinical trials, many funded by National Institutes of Health through grants to him. He also partners with companies to help them do a better job in testing their treatments. His work spans numerous neurodegenerative diseases that cause dementia, but with a strong emphasis on frontotemporal degeneration, and that's what he's going to talk to us about today. Thank you, Peter.
Thank you so much. It's exciting to be here to talk to you all about a general overview of the exciting things in the field of frontotemporal dementia. I just want to disclose that I'm a primary investigator on some of the clinical trials that I'll be discussing today. And just a general introduction to frontotemporal dementia. As the name might imply, this is a set of disorders that are caused by degeneration in the frontal lobes and then the anterior temporal lobes. And this contrasts Alzheimer's disease, which tends to involve atrophy and neuropathology in more posterior regions of the brain and in the memory centers of the brain called the hippocampi. And even though frontotemporal dementia is not as well known as Alzheimer's disease, I want to emphasize it's a major cause of dementia, particularly in people who develop dementia under the age of 65. I also want to emphasize that it's often familial. About 40% of cases with FTD have a strong family history, and many individuals who have a strong family history and have a diagnosis of FTD carry a risk mutation for frontotemporal dementia in one of three major genes: C9 open reading frame 72, progranulin, and MAPT, the gene for tau. And so just a general overview of what it's like to have frontotemporal dementia. People with frontotemporal dementia tend to present with disabling changes in either behavior or language. If behavioral changes are first, and the most disabling aspect, we call that the behavioral variant of frontotemporal dementia. If language changes are first, we call that primary progressive aphasia. And there's two forms of primary progressive aphasia that are closely associated with frontotemporal dementia. One involves changes in language fluency. We call that the non-fluent variant of primary progressive aphasia. And the other involves a loss of conceptual knowledge. We call that the semantic variant of primary progressive aphasia. And I'll be talking a little bit more about that version later on. And these three canonical variants of frontotemporal dementia are closely related to a few other disorders. One is called frontotemporal dementia with motor neuron disease. That's essentially FTD with additional features of Lou Gehrig's disease. And there's also two other disorders, cortical basal syndrome and progressive supranuclear palsy, which are sometimes mistaken for Parkinson's disease, but are really much more complicated than just Parkinsonism. And we consider them to be a family of disorders because all of these disorders have the underlying biology of frontotemporal lobar degeneration, so neuropathology in the frontal lobes and in the anterior temporal lobes. Although I do have to mention that sometimes Alzheimer's disease can mimic some of these clinical syndromes. I also want to mention that there are several subtypes of frontotemporal lobar degeneration, and there are two major subfamilies of frontotemporal lobar degeneration. One group involves frontotemporal lobar degeneration with collection of a protein called tau, which is also involved in Alzheimer's disease, although that tends to involve a different version of tau. The other major subtype of frontotemporal lobar degeneration involves mislocalization of another protein called TDP-43. We call that FTLD TDP. And these really account for the majority of frontotemporal dementia, although there are several more rare forms of frontotemporal lobar degeneration. I mentioned that Alzheimer's disease can sometimes mimic frontotemporal lobar degeneration, and fortunately we've known for a while that there may be good ways to distinguish Alzheimer's disease from frontotemporal lobar degeneration in individuals before they go to autopsy. One of these ways is with something called amyloid PET, a special kind of brain scan that can image amyloid beta, one of the proteins you've heard about today that is important with Alzheimer's disease. We've known for a while that patients with Alzheimer's disease have elevated levels of uptake of this tracer, and patients with frontotemporal lobar degeneration should not. But ultimately, it would be really great to just have a simple blood test that could achieve that purpose rather than a PET scan. It really does seem like that's now on the horizon based on recent research. We know that two proteins, two versions of tau, p-tau 217 and p-tau 181, can be measured in the blood and tend to be pretty good proxies for whether or not somebody has Alzheimer's disease or whether or not they would be positive on an amyloid PET scan. And recent evidence suggests that these biomarkers may be useful in distinguishing between people who have frontotemporal lobar degeneration and people who have Alzheimer's disease. So that's probably going to enter into clinical use in the not too distant future. Additionally, there are several biomarkers that may be useful for just telling whether or not somebody has neurodegeneration in general. These aren't biomarkers that are necessarily good for telling Alzheimer's from frontotemporal lobar degeneration, but they are quite elevated in frontotemporal lobar degeneration. So we've known for a while that a nonspecific biomarker of neurodegeneration called neurofilament light chain is elevated in the cerebral spinal fluid of individuals with frontotemporal dementia. Additionally, neurofilament light chain levels in the cerebral spinal fluid actually correlate quite well with levels in the blood. And more recently, it's become apparent that neurofilament light chain might have a clinical utility in distinguishing frontotemporal dementia from clinical mimics without neurodegeneration. The circumstance that I'm talking about is distinguishing primary psychiatric illness from patients with behavioral variant frontotemporal dementia. You can imagine, because patients may present with behavioral changes with FTD, they may be misdiagnosed with psychiatric illness. But patients with psychiatric illness will tend to not have elevated neurofilament light chain levels, and patients with behavioral variant FTD will. There's a whole other set of roles that we'd really like to develop biomarkers for in frontotemporal dementia, not just diagnostic purposes, but also we'd ultimately like to have a set of biomarkers that will be able to help us tell who's about to get frontotemporal dementia and basically give us a sense of what the prognosis might be in any one individual with frontotemporal dementia. We'd also like to have biomarkers that help us with the staging of disease, and ultimately this would all feed into a set of biomarkers that would be able to tell us whether or not a drug is working in an individual with frontotemporal dementia or an individual who's at risk of converting to frontotemporal dementia. And because of the relative rarity of any one form of frontotemporal dementia, in order to meet all these criteria, you really need large multi-site efforts to prepare for clinical trials in FTD. And these large multi-site efforts are necessary to identify patients over large geographic regions, collect longitudinal data and hundreds of biospecimens and hundreds of people, and allow for a broad search and validation of candidate biomarkers to prepare for clinical trials. And to this end, there are now several really important consortia that I'd really like to mention, some of which I work for. So one of these consortia is the All-FTD network. And All-FTD really has some of its roots in 2014 with two separate sister consortia, but it was renewed as this larger project called All-FTD that really joins together 23 clinical sites, major clinical sites of FTD research across the United States and Canada, and enrolls individuals into longitudinal research that collects clinical data, imaging data, collects biospecimens from blood and cerebral spinal fluid with approximately annual visits. And this project has a major emphasis on the familial forms of frontotemporal dementia. As I mentioned earlier, patients with mutations in C9 open reading frame 72, progranulin, and MAPT, and it enrolls both symptomatic and, crucially, asymptomatic individuals. These are individuals that have genetic risk for frontotemporal dementia, but haven't developed symptoms yet. So they're a cohort that you could theoretically study and make observations about who might be at risk of impending development of frontotemporal dementia. So you could theoretically develop trials to prevent people from developing their first symptoms. I also want to mention that All-FTD is now joined together with much larger initiatives. This is an initiative called FPI, which was founded as a collaboration between All-FTD and a very similar consortium called GenFi that exists in Europe and parts of Eastern Canada. And it's really to foster this sharing of longitudinal data and biospecimens to really foster the future of frontotemporal lobar degeneration clinical trials. And I'm really happy to say there's growing membership for similar consortia all across the world, all contributing to this effort. And because of efforts like FPI, we've been able to do some really exciting projects recently. This is work by a colleague of mine at UCSF, Dr. Julio Rojas. And Julio looked at cerebral spinal fluid and blood from individuals who carried these risk mutations for frontotemporal dementia. He made a really interesting observation in asymptomatic carriers of frontotemporal dementia risk. in these patients, these are totally asymptomatic patients, if they had high levels of blood neurofilament light chain, even though they were asymptomatic, those individuals were very likely to develop clinical decline in the ensuing years. And so this really lends credence to the idea that you could, in theory, develop prevention trials in these cohorts. Additionally, Julio was able to observe something that has previously been observed, that individuals who are symptomatic with the first stages or later stages of frontotemporal dementia, if they have a high neurofilament light chain level in their blood, they tend to have a more aggressive form of disease. And crucially, because of this collaboration, this worldwide collaboration under FPI, Julio was able to validate these findings in a similar cohort in GenFi. The next step has been to really look at every single data point that exists in all FTD and in GenFi. So really all of the patients that are contributing data to FPI and look at every single data point, annual data point, and see if we could look at things like neurofilament light chain and measures of clinical decline and imaging decline, and try to do some very sophisticated statistical modeling to see if we can paint a picture of how all of these different measures change in real time all throughout a person's lifetime when they have genetic risk for frontotemporal dementia. And this is work by another colleague of mine at UCSF, Dr. Adam Staffaroni. And so he did just this. He's done some very sophisticated statistical modeling. Here I'm picturing all of the data for NFL, plasma NFL, for individuals in all FTD and GenFi. And crucially, it's allowing him to paint a detailed picture of how biomarkers like neurofilament light chain change right in the onset of clinical symptoms. And he's been able to do similar modeling for clinical measures and imaging measures. And it's allowed him to paint this very detailed picture across the three major familial forms of frontotemporal dementia, of the different dynamics of these biomarkers, clinical measures, and imaging measures, and what they look like right in that lead up. One of the observations is that one cohort, the most common genetic form of frontotemporal dementia, C9 open reading frame 72 expansion, may have a slower incline over decades prior to symptom onset, whereas another disorder, progranulin deficiency, may have a much more rapid rise in something like neurofilament light chain in the years just prior to symptom onset. And we'd really like to drill down even further and get an even higher level of resolution on this. So that was data that was collected annually. Now there's a project, this is a project I'm the medical monitor for, called the Neurofilament Light Chain Surveillance Project. And this is a sub-project of all FTD. And really what we're doing is sending mobile nurses out to people's homes every 3 months to collect blood. And this is going to be done for years. And it's really focusing on asymptomatic and early symptomatic individuals in these familial frontotemporal dementia families. And it'll really allow us to have this high grade of resolution to know exactly what biomarkers like neurofilament light chain are doing right in that transition point when people might be developing symptoms, and really help us design the next wave of clinical trials. And so I've talked about logistical stuff. I really just want to cover in the next part just some of the really exciting things that are happening just in the field of frontotemporal dementia clinical trials, because there's a lot going on. One thing to mention is that there's a lot of different subtypes of frontotemporal lobar degeneration. And all of these clinical trials are targeting a specific biological process that may be unique to a specific subtype of FTD. And we don't yet have great biomarkers to distinguish all of those different subtypes, and individuals have not gone to autopsy. So currently, clinical trials really focus in on a few clinical cohorts that are known to be highly predictive of the specific kind of frontotemporal lobar degeneration on autopsy. This includes the syndrome called progressive supranuclear palsy, a cousin of FTD, which is really highly specific for tauopathology on autopsy. There's also a lot of attention on familial forms of frontotemporal dementia that highly predict TDP-43 pathology in autopsy. And I'll mention at the end, I'm leading a trial in another disorder called semantic variant primary progressive aphasia. I'll zip through this slide. There's so much detail, I'm not going to go over all of it, but I just want to start by talking about different therapeutic approaches in frontotemporal lobar degeneration with tau. And one of the possible ways to, at least in theory, limit tau pathology is to decrease the amount of tau that brain cells are making. One way you could theoretically do this is by a drug class called antisense oligonucleotides. These are RNA-like artificial molecules that you have to infuse into the cerebral spinal fluid. And they're able to target and suppress a specific gene. And one of these drugs has been used in Alzheimer's disease and does seem to robustly suppress the amount of tau that's made. So the question is whether or not the similar approach would be useful in frontotemporal lobar degeneration. There's now an ongoing trial in progressive supranuclear palsy, which I'm excited about. So we're going to see if this actually may have a similar effect in that cohort. An additional potential therapeutic strategy in frontotemporal lobar degeneration with tau might also include helping brain cells clean up the amount of tau that they have through a process called autophagy, or limiting the amount of toxic changes that brain cells make to their own tau. We call that post-translational modification, or one of which is something called phosphorylation. And a set of enzymes that are involved in both of these processes are these Rho kinase enzymes. They're inappropriately activated in individuals who have frontotemporal lobar degeneration with tau, and there are multiple drugs that can suppress Rho kinase activity. One of these drugs, Fasidil, can be taken orally and can enter into the CNS. And I'm currently running a clinical trial of Fasidil at UCSF that's enrolled 10 patients with PSP and 5 patients with cortical basal syndrome, and we expect a readout later this year. And there are many other clinical trials programs in FTLD tau that I won't have time to get into. I also mentioned that there's a lot of emphasis on genetic families that predispose to specific subtypes of frontotemporal lobar degeneration. One subtype that's gotten a lot of attention are families with this mutation in the progranulin gene. These mutations are highly associated with TDP-43 pathology, and they all result in this common mechanism of decreased amount of progranulin. And so this progranulin protein is a rational biomarker for drug target engagement. If you can boost it in the cerebral spinal fluid, you could rationally assume that you are doing something to combat the method of pathogenesis for that particular mutation. And the clinical trial program that's furthest along in this subset of frontotemporal lobar degeneration is in this drug, AL001. It essentially blocks a degradation pathway for progranulin. And this is data from symptomatic individuals enrolled in a phase 2 trial. And as you can see, the progranulin levels in the cerebral spinal fluid do seem to robustly increase after treatment, up into the level of normal individuals who do not have the mutation. And for what it's worth, biomarkers like neurofilament light chain seem to be relatively stable in individuals receiving treatment. And this was an open label trial, but when patients were compared to historical data for similar patients from the GenFi cohort, they did seem to be doing a little bit better clinically. And so ultimately, you'd really need a phase 3 clinical trial that's double-blind and placebo-controlled to follow up that finding, and that's exactly what's happening right now. So this trial is currently enrolling both symptomatic individuals with progranulin deficiency and asymptomatic individuals, really honing in on this idea that you can look at specific biomarkers and tell which asymptomatic individuals may be at risk of developing frontotemporal dementia in the next year, and you could theoretically enroll them in a clinical trial. And there's a lot of other clinical programs going on in progranulin deficiency, including gene therapy programs, and more recently a drug that's about to enter into trial that is essentially an altered form of progranulin that you can give through the blood, and it can enter into the brain and supplement brain levels. Just wanted to also cover clinical trial programs in C9 expansion. So expansion of the C9 open reading frame 72, it's the single most common genetic form of ALS and frontotemporal lobar degeneration. And it involves expanded repeats in this region of this gene. That expanded area of the DNA can give rise to expanded RNA molecules, which can be toxic. And those expanded RNA molecules actually give rise to these particular kinds of proteins called dipeptide repeat proteins. And for what it's worth, another ASO therapy, these ASO therapies that are infused into the cerebral spinal fluid, has been used in this cohort and does seem to be able to stabilize, or at least in one individual who had ALS due to C9 expansion, they seem to be clinically stable, and the drug did seem to suppress their detectable dipeptide repeat proteins. And another drug, in the interest of time, I'm going to speed through this, but another drug is currently entered into trial in both patients with FTD and ALS. And has had similar findings with dipeptide repeat proteins in the cerebral spinal fluid. And I'm going to zip right through this, but there are many other programs in C9. I just want to finish by talking about a program that I'll be leading, and I'll start by talking about a mechanism that may be useful across the spectrum of frontotemporal lobar degeneration with TDP-43 pathology and isn't particular to a specific genetic form of FTD. So the brain has immune cells. We call them microglial cells. And there are certain situations in which those microglial cells may be inappropriately activated and produce something called oxidative stress. And we know that certain kinds of oxidative stress can promote the mislocalization of TDP-43. This is the hallmark feature of frontotemporal lobar degeneration with TDP-43 pathology. And there are certain drugs that could, in theory, block certain kinds of oxidative stress that may be important to frontotemporal dementia. One of these drugs is a drug called Verdiperstat, which is actually currently being investigated in clinical trials with ALS. It blocks an enzyme called myeloperoxidase, and thereby blocks a certain kind of oxidative stress from microglia. So I'm currently leading a trial that is funded by the NIH and the Alzheimer's Association Part the Cloud program. It's the Veri-T trial. It's a phase 1 trial, double-blind placebo-controlled trial investigating Verdiperstat in patients with semantic variant primary progressive aphasia. It's actually the first clinical trial that will be using that large all-FTD network as a recruitment resource to identify patients and route them to participating sites. And it's actually the first clinical trial that will ever focus on this disease set, semantic variant primary progressive aphasia. The reason I selected that disease set is because that particular form of primary progressive aphasia is very specific for frontotemporal lobar degeneration with TDP-43 pathology. So we're really rationalizing this disease set as a potential model cohort in which to design many other future trials targeting frontotemporal lobar degeneration with TDP-43 pathology. So we're trying to develop an overall methodology for future svPPA trials and create an opportunity for biomarker research within this cohort. I also want to mention one other fun fact, that this will be the first trial to implement this new all-FTD app, which is a remote cognitive assessment app that we think will be really useful for future frontotemporal lobar degeneration clinical trials. And so we're now enrolling, so if you know any patients with semantic variant primary progressive aphasia, please contact me. I'd love to hear from you. And with that, I just want to thank you all. Thank you for your attention. I'm so happy to be able to talk to you today. Thank you very much.
That was great. We have time for a question or two. People are calling all their folks they know. We have a coming to you. She's coming.
Sorry.
You're okay. Right behind you.
Right.
Microphone.
Oh, thank you. Earlier when you started, you were talking about the biomarkers. I have a question. I may even need you to help me ask it. When my sister had Alzheimer's, about the same time she was diagnosed, she was developing a lack of appetite. And this lack of appetite activity continued right along with the increased Alzheimer's symptoms. And eventually she actually died of not eating. Not a bad way to go when you're going with Alzheimer's at that time. This was 4 years ago. And they would ask me to stay at the center where she was living, and because she would eat more food for me. And I'd try to get her to take a third or fourth bite, and she'd say she felt like she would get sick. She really tried to cooperate. Now, I've not heard of this. Is this a symptomatic condition for some people with Alzheimer's? If so, is it something significant to know? Her regular doctors that she saw, that she'd been seeing all her adult life, didn't pay much attention to it. They said, oh, she probably had something else. And I said, you've tested for everything else, And she was about 80 pounds overweight, and she died from not eating. Thank you.
Yeah, thank you for your question. So decreased oral intake is something that does frequently happen in patients with Alzheimer's disease. It doesn't happen in all individuals, but many individuals cope with weight loss during different stages of their disorder. And this is in contrast to FTD, in which patients may actually eat in excess, whereas in Alzheimer's disease, patients may frequently eat a lot less and have the early satiety. So it does happen. Thanks for your question.
We're going to bring the microphone to you. In the meantime, Peter, just maybe some quick thoughts about individual disease pathology trials versus basket and platform trials. Do you think there's a role for both? Do you have a preference? You guys have done some really amazing stuff with enrolling people with different tauopathies in a
Right.
single trial.
I think that there's a role for both basket and platform trials, and I think they're a really exciting way to conduct trials in FTD research. So a basket trial is you get a lot of different disorders that are biologically related. They might not be the same clinical syndrome, but you know that they're biologically related, and you enroll them in one clinical trial with the same drug and see and essentially make some early observations about drug target engagement in that trial. It was invented for cancer research, and I really do think it's a very useful tool for designing clinical trials in rare disease sets, including frontotemporal lobar degeneration. You're right, yes, we did run a tau basket trial at UCSF. I also think that platform trials are extremely useful, particularly when you're thinking about relatively rare disease sets. You know, some of these conditions that I mentioned, you know, we have so many different trials programs. Any one trial program may be disadvantaged in terms of finding patients and enrolling patients. And so recently, so the ALS community is actually really leading in this. They have a large ALS platform trial that enrolls many, many individuals into different wings, and they essentially share a placebo group. So you can still have a placebo-controlled trial, and you can still test a lot of different drugs, but you're really maximizing the amount of individuals that get assigned to an active treatment in that trial. And you could design it as a rolling design, so you can continue having wing after wing in which you're introducing new groups of patients that are randomized to different drugs. And I think it's a really innovative way to conduct trials in a rare disease set. And I do think that we're going to be seeing platform trials in FTD in the future. I definitely think it's going to happen. It's a matter of when. Yeah.
Okay, right here.
Is the treatment for FTD and Alzheimer's the same? Like the medications, are they similar or are they treated differently?
That's a good question. So I should emphasize, FTD doesn't have any disease-modifying therapy, so we don't know, despite the exciting things that I said about trials, we don't yet know of a way to slow the disease process. There are treatments that can, at least in theory, help with some of the symptoms. I do want to emphasize the typical treatments for Alzheimer's disease, Aricept and similar drugs, Namenda, they are not thought to be efficacious in patients with frontotemporal dementia. And this is part of why it's important to actually hone that diagnosis about whether or not they have Alzheimer's or FTD. I will say that there is small trial data and several other symptomatic therapies. I think the drug class that probably has the best data behind it is really serotonin reuptake inhibitor medications. These aren't large trials, but I can tell you anecdotally they can help with managing some of the behavioral symptoms of behavioral variant frontotemporal dementia. And they tend to be first line when we do use a pharmacological therapy in individuals.
Last question. I think people are.
Hi, thank you so much. Very, very interesting. I'm a medical speech pathologist, and so semantic variant that's right up my alley. So thank you, very important. I just wanted to toss out a thought to the person who had a relative with swallowing difficulties and just mention that in the middle to late stages, people oftentimes have oral motor difficulties and dissolution of motor skills, and so that could possibly be a reason. And a reason to refer people to speech pathologists so we can do a swallowing evaluation for you. So.
Just about the value of speech pathology. I know Mario used to refer a lot.
Yeah, that's another great point. Actually, just the value of SLPs. Actually, my wife is an SLP, so they're very close to my heart. But so speech pathologists are a great cohort to get involved, particularly with primary progressive aphasia variants, so they're really the primary group of therapists that can help people with language disorders, and as you mentioned, with swallowing disorders that become common across the spectrum of neurodegenerative diseases, particularly in the later stages. So thank you for that comment. Yeah.
Great. I think we should thank Dr. Ljubenkov.
Thank you very much.